Hey everybody, my name is William Adams, and today is July 30th, 2019. Today I'll be doing my Case Connections Unit 4 video script discussion. So the two cases that I chose today were Case 2 and Case 3. So I'm going to start off by telling you a little bit about each case, and then I'll get more into it as I go. So starting with Case 2. In Case 2, a 4-year-old infant is demonstrating higher than normal levels of phenylalanine. Her levels of phenylalanine was 6.6 milligrams per deciliter, while the normal range was 1 to 2 milligrams per deciliter. A diagnosis of phenylketonuria, or also known as PKU, was made but the family denies a known history of PKU. Everything about the birth and pregnancy were presumed normal, and the infant girl weighed in at about 5.9 pounds at the time of her birth. The diagnosis given to the girl was phenylketonuria, which means the inability to metabolize phenylalanine. The primary enzyme that breaks down phenylalanine is phenylalanine hydroxylase, which uses tetrahydrobiopterin as a cofactor. Phenylalanine is an essential enzyme that can be transaminated to phenylpyruvate and further generate phenylacetate or phenylactate. When it's metabolized, it can be used to synthesize tyrosine or another amino acid. Tyrosine is a non-essential amino acid as long as phenylalanine metabolism is functional. Without proper metabolism of phenylalanine, PHE, is how I'll use it from here on, tyrosine becomes an essential amino acid. Tyrosine is required for the production of melanin, the production of epinephrine or norepinephrine, and the production of thyroid hormone synthesis. It is also able to be transaminated to form TCA cycle intermediates such as fumarate, and acetate, or acetoacetate. So as you can see, without tyrosine either being consumed in the diet or being produced by the metabolism of PHE, there's a multitude of processes that can be affected. After being placed on dietary restriction therapy that limited the infant's intake of PHE, her levels dropped back down to 1.65 milligrams per deciliter, which is within the normal range. PKU is found to be genetically inherited with problems associated with the phenylalanine hydroxylase enzyme, or it can also be associated with complications to the BH4 cofactor, which is also known as the tetrahydrobiopterin. Without the functional cofactor, which is required for hydroxylation reactions, basically the cofactor is required for all hydroxylation reactions, and without it being functional, there is no metabolism of PHE to tyrosine. When BH4 loading tests were done on child A, or the child that we've been discussing, which I'll be referring to as patient A, alongside another child who is suspected to have PKU, which I'll be referring to as patient B. There was no patient A had no decrease in phenylalanine productions after BH4 loading, while patient B, which is the other child we haven't really been discussing, we see that the BH4 loading did decrease the levels of her phenylalanine after a meal. So basically, what does this mean? So patient A must have the inheritable form of PKU. So PKU is an autosomal recessive disease and is only shown when both the father and mother are carriers, and that is why the family had never shown signs of PKU, because they were only carriers. Nobody actually had symptoms of PKU, whereas patient B had the form which is associated with a faulty BH4 cofactor. So that was it for Case 2. Now I'm going to get on to Case 3. So Case 3, in this case, we see that a 47-year-old man has experienced severe pain in his big toe of his right foot. There is no trauma to this area, and this pain is not desisted since its appearance. The pain is so intense that he's unable to put weight on this foot, and after further examination, he was determined to have a medical condition known as gout. Blood testing and urine analysis results came back showing that the plasma urate levels were outside of the normal range. The normal range for plasma urate is less than 7 milligrams per 100 milliliters, and his plasma urate levels was 10.5 milligrams per 100 milliliters. The normal range for the uric acid levels of the urinary tract should be within 335 to 491, and that's milligrams over a 24-hour period. So our patient's urinary sample had a reading of 215 milligrams per 24-hour period. This means that the excretion levels of the uric acid are low, and the blood levels of uric acid are high. As learned from our coursework, we know that gout can be caused from an overproduction of purines, a decreased salvation of purines, or a decreased urinary excretion of uric acid, all of which stem from hyperuricemia. So decreased salvage of purines is usually common with a deficiency of the HGPRT enzyme that is associated with Lesch-Nyhan syndrome. So Lesch-Nyhan syndrome is a genetic disorder that has a X-linked recessive inheritance pattern, so usually only found in males. I don't believe that that the decreased salvage of purines is the reason that our patient's gout because the urinary excretion functions properly with this disease, but it also has a high strain on the kidneys due to excess uric acid in the blood. It is a very uncommon disease, and people who have this disease typically don't live past the age of 20 years old due to renal failure. Decreased excretion of uric acid was a symptom seen in our patient's urinary sample, but I don't believe that this deficiency caused the gout, because this is because under excretion of uric acid is primarily associated with excess alcohol consumption. In fact, males who consume 2 to 4 alcoholic beverages a day are 1.5 more times likely to develop gout flares. In fact, there is no mention of the patient consuming alcohol. However, there is a mention that the patient drinks soda, and that's not a small amount of soda, it's a lot of soda. He explained that he drank 4 to 5 liters of soda a day, and recently switched over to drinking non-diet due to fake sugars in diet soda. And this, I believe, was the cause of the gout flares, because of the high levels of sugars in this soda that's now non-diet. The excess sugar produces more glucose 6-phosphate, and subsequently it produces more ribose 5-phosphate. When there's excess ribose 5-phosphate, the body activates the pentose phosphate pathway, which produces more nucleotides. The unused nucleotides can then be broken down into uric acid, explaining why the high rate of urate in the plasma. Excess unused sugar molecules from the soda are the underlying cause for his gout, but it does not explain why the urinary sample was below normal. Therefore, I would really like to know if the patient drinks alcohol with his soda. That could explain why the underexcretion of uric acid from the kidneys. Thank you guys so much for listening to my case connections. If you would like to see my sources, I had a couple different sources. They are located right here, and I will be posting that online as well. If you have any questions, please post them in the comments, and I would be happy to get back to them. Thank you guys so much, and hope you guys have a wonderful day.